All right, thank you for joining me today for today's event where we're going to talk about lipid panels under the lens and how you can avoid denials with competent compliance. My name is Mary Sue Gardner, and I'm a registered nurse on the Provider Outreach and Education team. And I'm going to be your facilitator for today's event. And I'm also joined today by other members of the Provider Outreach and Education team, as well as medical review, and they're going to be helping me with the chat and question and answer portion of today's call. A few housekeeping items before we get started. On our website, WPSGHA.com, we have a training center link at the top of that page. In our training center, you're going to find all things education, such as training materials like the slide deck for today's event. You're going to find upcoming educational events and access to our encore presentations, which are the recordings of our live event that you can also watch outside of YouTube. We have a built-in YouTube player. Those encore presentations are generally on our encore page for about 60 to 90 days, but they're always available on our YouTube page until that information is either changed or updated. If you have any questions during today's event, you can go ahead and place those in the chat and send those off to us. If you have any feedback about your experience today, and we sure hope that you do, there is going to be opportunity right now and at the end of this event to take our survey. Jennifer placed the link to that survey in the chat. In case you find you need to leave this presentation a little early, we do encourage you to use that survey link and go ahead and give us your feedback. If you are listening as an encore, we also encourage you to take the survey. The encore survey link should be in the top right-hand corner of the screen. It'll be a little eye with a circle around it, but it's also available in the description of the presentation. On your screen now is a disclaimer that we have to give at every event. Basically, our disclaimer says the information I'm giving you today is as good as it is today. Knowing as a Medicare provider that Medicare laws, rules, and regulations often change. It is your responsibility as a provider to make sure you are following the most current laws, rules, and regulations that are in place on the day of service that you're providing them. So everything we're going to talk about today is current as of today. So if CMS changes their mind tomorrow, it's your responsibility to make sure you're following those updated rules tomorrow. All right, and then we ask that you don't audio or video take this presentation for any profit-making purposes. We're recording it for you, so you shouldn't need to do that anyway. This slide is just a list of acronyms that are may or may not used during this presentation today. So if I spit out an acronym and you don't know what it means, just go ahead and refer back to this page. Otherwise, if I use an acronym and it's not on this page, just place it in the chat and one of my associates will help answer what it means. All right, the objective for today. What do I want you to get out of today's event? I really want you to learn about the documentation strategies to help remain compliant if you are ever reviewed for your lipid panels. And we're going to accomplish this objective today by reviewing the coverage criteria for lipid panels. We're going to talk about those essential documentation requirements. And then we're also going to talk about some of the common medical review findings and overall causes of denial. Let's get things started today by reviewing the indications and limitations of coverage. All right, starting with the indications. First, what does indication mean? Well, it means it's a sign or symptom or medical condition that justifies a particular treatment, test, or procedure. So that's how indication is defined. Under the indications and limitations in the NCD for lipid panels, which is 190.23, and I'm going to have Jennifer place that into the chat. The medical community recognizes lipid testing as appropriate for evaluating atherosclerotic cardiovascular disease and conditions in which lipid testing may be indicated. And those things include an assessment of patients with atherosclerotic cardiovascular disease, evaluation of primary dyslipidemia, any form of atherosclerotic disease or any disease leading to the formation of atherosclerotic disease. Diagnostic evaluation of diseases associated with altered lipid metabolism, such as like nephrotic syndrome, pancreatitis, hepatic disease, and even hypo and hyperthyroidism. Secondary dyslipidemia, including diabetes mellitus, or disorders of the gastrointestinal absorption or chronic renal failure, and signs and symptoms of dyslipidemia. Oh my goodness, words are hard today, such as skin lesions. Okay, so continuing on to the next slide. So some of the additional indications as a follow-up to an initial screening for coronary heart disease, where total cholesterol plus HDL cholesterol is used when the total cholesterol is determined to be higher than 240 milligrams per deciliter, or it's considered to be borderline high. So high, greater than 240, or borderline high, in that range of 200 to 240. Plus, 2 or more coronary heart disease risk factors, or an HDL less than 35. So I really want you guys to pay attention to anytime we have ors or ands, because those are going to be the things upon review that we are looking at. So as a follow-up to initial screening for coronary heart disease, when total cholesterol being high, or it's borderline, or the HDL is greater than 35. All right. So to monitor the progress of patients on anti-lipid dietary management and pharmacologic therapy for treatment of evaluated blood lipid disorders, the total cholesterol, HDL cholesterol, and LDL cholesterol may all be used in that monitoring process. So triglycerides may be obtained if the lipid fraction is also elevated, or if the patient is put on drugs, like for example, like thiazide diuretics or beta blockers, even estrogens, glucocorticosteroids, tamoxifen, which are all things that can raise that triglyceride level. So when you're monitoring the long-term anti-lipid dietary or pharmacologic therapy, and when following a patient with a borderline high or LDL cholesterol, it may be reasonable to perform the lipid panel annually. So a lipid panel at a yearly interval will usually be adequate, while measurements of the serum total cholesterol or a measured LDL should suffice for like interim visits if that patient does not have hypertriglyceridemia. Any one component of the panel or a measured LDL may be reasonable and necessary up to 6 times the first year for monitoring dietary or pharmacologic therapy. So more frequent total cholesterol, HDL, LDL, and triglyceride testing may be indicated for marked elevations or for changes to anti-lipid therapy due to inadequate initial patient responses to things like dietary or pharmacological therapy. The LDL cholesterol or the total cholesterol may be measured 3 times a year after treatment goals have been achieved. So, I lost my brain thought for a second, but we're going to move on. But what I wanted to really hone in on is the fact that we need to make sure that if we are doing things more frequently than our local coverage or national coverage determination allows, that we are documenting why that frequency is necessary. So are there changes? Are there market elevations in some of those other tests? Those are going to be the things upon review that we are looking for. So again, computer going crazy. So let's talk about some limitations. We talked about the indications, but there's also limitations. Those limitations include routine screening and prophylactic testing for LDL disorders. Those things are not covered by Medicare. While lipid screening may be medically appropriate, Medicare by statute does not pay for it. So lipid testing in asymptomatic individuals is considered to be a screening, regardless of the presence of other risk factors, such as family history, tobacco use, etc. Once a diagnosis is established, one or several specific tests are usually adequate for monitoring the course of the disease. Less specific diagnoses, for example, like other chest pain, which is not real specific, those alone do not support medical necessity of these tests. Remember, as we talked about in the covered indications, any one component of the panel or a measured LDL may be medically necessary up to 6 times the first year for monitoring dietary or pharmacologic therapy. And more frequent total cholesterol, HDL cholesterol, LDL, and triglycerides may be indicated for those marked elevations or for changes to the anti-lipid therapy due to that inadequate initial patient response to those therapies. So the LDL cholesterol or the total cholesterol may be measured again 3 times a year after treatment goals have been achieved. If there's no dietary or pharmacologic therapy advised, monitoring for this patient is not necessary. Now let's switch gears a little bit and move on to the documentation that is necessary for successful reviews. So CMS has authorized WPS to conduct targeted probe and educate reviews on lipid panels. On this slide, we've identified the documentation requirements that are necessary for you to support the intent of the lipid panel laboratory test and to support the covered indications that are listed in the NCD. So those include a signed provider order. The order should list if it's a full panel or if there are individual components that should be performed. Progress notes should be provided. Progress notes to support a covered condition. So again, there must be a clear indication within the chart of the diagnosis to support the reason for the test or for additional tests. Also, any symptomology that may warrant the test. A lot of times that is in the progress notes as well. Primary diagnosis build. There would be an expectation that the progress notes also contain the documentation to support the primary diagnosis that's billed on your Medicare claim. Other components of documentation. We're going to need a current medication list, as we talked about earlier. So if there are pharmacologic managements that warrants the test, then we need to know what meds, how often, etc. Any laboratory tests that are done for this patient, past or present, any current or prior tests within that past year. So keep in mind when the NCD says a year, that is the next month after 11 full months have passed from the last test. So if it was January of 2024, then you need to get through December of 2024 before you can test again. The date itself, then after that, does not matter. It's not 365 days, it's the next month past 11 months. All right. And then finally, advanced beneficiary notice of non-coverage, if it's applicable. So if you issue an ABN, you should have done so because you had reason to believe that Medicare may not cover the test for that person on that particular day. It should not be routine to issue an ABN because there are time limitations on tests. Providers need to do their due diligence and look into when the last test was performed, look into if the testing meets the medical necessity of performing that test. And if you have reason then to believe that in this case, for this venue on this day, Medicare may not pay for that person to have that test, then you should issue an ABN. If you do, and we request your documentation for review, you need to supply us that advanced beneficiary notice of non-coverage as well. Although we're not really going to get into billing lipid panels, as this is a clinical webinar, I want to discuss a few modifiers that we would expect you to have on your billing and probably note in your documentation. So really quickly, modifiers GV and GA may be necessary to put on your claim with your lipid panel in the following conditions. So if you issued the patient an ABN because you expect Medicare is going to deny as not medically reasonable and necessary, you have reason to believe that, you would need to put the GA modifier on the claim. Again, we would need to see the ABN included in your documentation as well. That's going to indicate that the patient knows if Medicare does not pay for this service that they are financially liable. So in other words, a claim denial is going to result in the beneficiary being liable for the claim. If you expect Medicare to deny the lipid panel is not medically reasonable and necessary, and you didn't issue your patient an ABN, meaning the patient or beneficiary didn't know they would be financially liable if Medicare doesn't pay, then you would need to append the GV modifier to the claim. That way, if the claim does deny, you as the provider are liable. So now let's move on and talk a little bit about the actual review by our medical review staff. Things that the review nurses are going to look for when we review a claim for lipid panel. So is the diagnosis code billed on that, the one that's on the claim, indicated as a covered diagnosis code per the NCD and laboratory PDF. There is not a link to the laboratory NCD in the presentation, but I'm going to have Jennifer provide a, you know what, I will show you how to get there because I didn't send the link to Jennifer. And then we'll put it into the actual chat as well once we go out there. All right, other things we're going to need are the physician order or assigned physician documentation to support intent. So if we don't get the order, then we're going to have signed progress notes that really show the intent that the physician planned on doing this laboratory test. Other components we're going to look for are the documentation to support that covered diagnosis. We're going to look to see, does the diagnosis support the need for the lipid panel? Are there symptoms documented related to the diagnosis? We're going to look for current medication. We're going to look for laboratory reports. Per HIMR and documentation, we're going to look for a list of all lipid panel tests billed to Medicare within the last 12 months prior to the date of service under review. So if it's not in your documentation, we will use the system, we will use the HIMR system to go back and look to see if you are within your 12 months accordingly. If one or more lipid panel tests have been performed within a year to the date of service under review, we're going to look to see, was it elevated for for diagnostic purposes, or was it used for diagnostic purposes? All right, does the documentation support the medical necessity of the lipid panel? And is the date of service under review for the lipid panel test, was it for monitoring for long-term anti-lipid dietary reasons or pharmacologic therapy reasons or borderline high or high total or LDL cholesterol levels? Okay, I do see before we move on, we have a question. When we issue an ABN for the reason of exceeding the frequency limitations, the claim is paid without a denial. Why isn't it denied? It seems that there is no incentive for providers to follow the frequency limitations. That's an interesting question, Sandra. You are billing knowing you are outside of frequency limitations and it is still being paid. That's one thing I'm going to have to look into and see if there's an auto denial that is not working properly. However, knowing that you shouldn't be paid and still billing Medicare, if you know that it's something that should not be paid, you should not be billing Medicare. Once you know you're not following the rules and you still continue to not follow the rules, that could potentially borderline on fraud, waste, and abuse. However, in this case, there are reasons that you could do tests outside of frequency limitations because of elevated components, changes in labs, changes in dietary, changes in pharmacological. So I am going to look and see if there is, though, a frequency limitation edit that's out there, and I'll put that out to everyone after the webinar if I find anything about that. All right, and we bill with the GA because the ADN instructions say to submit the claim for a denial if the patient chooses option 1. So you're using the GA and it's still paying. Okay, I'm going to have Jennifer jot those things down, and I will go back to our claims processing department and see if I can find anything out about that. All right, perfect. Thank you for your question. And like I said, I'll get back to everyone with the email follow-up after I find out more from our MIP department. So the review continued. If one or more of the lipid panel tests have been performed within a year to the date of service under review, was it to monitor for long-term anti-lipid dietary or pharmacological therapy and or borderline high total or LDL cholesterol levels? So those are one thing, we're going to look at if we see that, we're outside that frequency limitation. If the date of service under review is the only lipid panel test to have been performed within a year to the date of service, was it to monitor for long-term anti-lipid dietary and or pharmacological therapy and or, your borderline high total or LDL? So again, keeping in mind the frequency limitations, we're going to look for why tests are being done. Is the date of service under review for the lipid panel test to monitor for non-specific chronic abnormalities of the liver? It's one thing we're going to look for as well. So if one or more of the lipid panel tests has been performed under the dates of service under review, was it for non-specific chronic abnormalities to the liver? Has the lipid panel test been performed more than twice annually? We're going to look also to see, does the patient have a history of severe psoriasis? Is the patient being treated with a retinoid? These are all things that could affect the lipid panels, could affect those blood levels. So again, when we say we need things like what kind of medications is the patient under, why are we, monitoring, what kinds of symptomology does the patient have, or what are we keeping track of? These are some of the things that we are asking when we're going through your documentation and looking at it. Is the test routine? Is it prophylactic testing for lipid disorders? Again, is the patient symptomatic? If they are symptomatic, let us know the symptomology that they're exhibiting. Just as a reminder, Medicare does not cover routine screening or prophylactic testing for lipid disorders. This is why the documentation really must support the medical necessity of the services and the clinical rationale for any repeat testing. Without that information, it could look like your lipid tests are being done routinely, and they could possibly be denied upon medical review. So moving on, let's talk about some of the common review findings that we are finding when we do medical review. All right. The three most common review findings include exceeding frequency limitations, documentation that doesn't support the medical necessity of the services, and lipid panels that are done for routine screening. So let's break all those down a little bit more. So exceeding frequency limitations. One of the most common errors our medical review nurses see during the lipid documentation review includes exceeding frequency limitations. This is really straightforward. As I mentioned, Medicare covers diagnostic lipid panels. We cover those annually when you're monitoring the long-term anti-lipid dietary or pharmacologic therapy, and when following patients with that borderline high total or LDL cholesterol level. Any one component of the panel or a measured LDL may be medically necessary up to 6 times the first year for monitoring dietary and pharmacologic therapy. So the LDL cholesterol or total cholesterol may be measured 3 times a year after your treatment goals have been achieved. So remember, we're going to use the instructions as listed in that NCD, and we're going to pop out to the NCD in a little bit, and we're going to make sure you are following those frequency limitations. If they are being exceeded and there's no documentation to support why, we're probably not going to pay for those services. All right. The next one is documentation does not support medical necessity. So no explanation for the lipid panel test. So you have to have a need to support the medical necessity with your claim. And to support, it's not just for routine screening. For medical necessity, we again are going to look for those indications of coverage and why this patient needs it and why they need it on this day. Is there symptomology? What's the rationale? If there's nothing there and you're only submitting a list of labs or just a lab order when we request medical review documentation, we can't pay for it. We can't just pay based on a lab result. We have to see the rest of the medical necessity components along with that. This is one thing when sometimes a lab themselves are called upon for medical review. So a laboratory may need to get the information from the provider's office to support the medical necessity of the service on that day that the laboratory runs and bills for that service. So Part B physician offices and independent laboratories, you have to play nice with each other. And if the lab requests the documentation, the progress notes, the orders, etc., the medication list from the provider's office, you do need to supply them with that information so the lab services can be processed. All right, and finally, the last common denial that we see is providing lipid tests only for routine screening purposes, multiple times in a single year. We've seen it. It's not something Medicare covers. So I do want to note, however, when it comes to routine screening, we have some misuse in exceeding frequency in the use of the ABN to cover that. This is something our nurse reviewers see from time to time, so I did want to mention it today. So in our reviews, we've seen provider doing lipid panels at higher frequencies than allowed by Medicare, and then providing the beneficiary with the ABN form, sign that form, and then the beneficiary is liable for payment. While technically this is allowed, we do question if the beneficiary fully understands the out-of-pocket cost. So you need to make sure you are doing all that paperwork appropriately, you're filling out your ABNs correctly, you are noting that your beneficiaries, understand that there is a financial liability for them to have testing that Medicare is possibly not going to pay for. Many patients aren't going to question their healthcare provider if they're told they need certain lab tests done. So for lipid panels, please do not bypass those Medicare frequency limitations by just automatically, doing them outside the limitations, issuing an ABN form unless it's truly medically necessary that that beneficiary receives that additional lab test. And if that's the case, provide them the detailed documentation to support that indication and make sure you're documenting that clinical rationale for that lipid panel beyond the limits. Issue that ABN appropriately, append the GA modifier appropriately, and submit it. And again, if it comes into question in medical review, we are going to look for that documentation to support why it was done, even though it is beyond the frequency limitations. Is there medical necessity justification? Okay, and then on your screen, I have some resources. And I am going to actually link out to the national coverage determination here really quick, because I want to show you how to also get that laboratory NCD information. And there's more than one way to get there. So we're just going to go here because I already have it up. But quickly, this lipid testing NCD is 190.23. I'm going to go all the way and back right out into CMS.gov. There's a lot of different ways to get there. I'm going to show you an easy one. If you go to Medicare coverage database, and then you type in 190.23 and enter, you're going to get to lipid panel testing. Even if you can't remember what the number is, and I went back too far, and I go in here and I put lipid testing. And then you see in your available list, oh, here is that NCD. This is going to give you all those indications and limitations of coverage that we just talked about today. It alludes to some of the documentation requirements that we talked about as well. But if it is an indication or a limitation of coverage, if there's a frequency limitation, it's all going to be listed here. I encourage you, if you have not read this, if you are not familiar with this, and you do lipid testing, that you do go out, learn this, live this, love this. It's going to be of utmost importance to you to understand what those limitations are. And if it says that you have to have something as an indication of coverage, we're going to expect that that is documented and in your documentation if we ever review it. I did receive some pre-submitted questions about where can I find like covered ICD-10s. So if you saw, I scrolled down to the bottom, and actually I'll back up one spot here. I downloaded this, just so you know, and it comes up as a zip file. And this is the most frequent laboratory code list. And I'll just pull this over and you can see it downloads the zip file. I'm going to open this PDF, move that off the screen. And a lot of you, if you've been around Medicare for a long time, you're probably familiar with this laboratory NCD manual. I am going to go down because I have written this down in advance to page 1719, and that is where the lipid panel testing starts. So I encourage you to drop or to make note of that, because 1,700 pages is a lot to scroll through to find this. You can do a control find and go through and look for like 190.2 or look for lipid testing. It just takes a little longer. But as you scroll through this, here's going to be the HCPCS codes for the testing itself. And then down here starts the ICD-10 codes that also support the service. So if you were looking at codes to support the service, this is where you're going to find them. Now I'm going to tell you that this is probably, I can't even guess, 50 pages long of codes. I mean, it goes on and on and on for this NCD. And you can kind of make sure you're still in the correct NCD. On every page, it's going to be listed at the bottom. But there are pages and pages and pages of associated codes. So again, I do encourage you to go out and take a look at that. And if you're wondering again where I went to find that, I went to the lipid testing NCD. I scrolled all the way to the bottom and I opened that ICD, I opened that lipid NCD. I opened the laboratory NCD manual from the most current one that's published, which is January of 2025. An update will come out in October of 2025 as well. So again, if new codes are going to be added or deleted, that's where you're going to find them after October. Okay. So let's go back to the PowerPoint. And again, this will take you to some lipid panel information on WPS GHA. So a quick recap. That was a lot of information in a little bit of time. But today we learned about what kind of documentation strategies are going to help you maintain compliance if you are reviewed. So we went through that coverage criteria for the lipid panels, and I took you to the NCD so you can see where you can find these coverage criteria as well. We went over what kinds of documentation requirements are essential for this, and we then discussed some medical review findings and causes of denial and things that should help you avoid a denial yourself if you happen to ever be reviewed. So let's see, I'm going to look over to the chat. If you go to Medicare Preventive Service Tool, it shows 80061 under cardiovascular disease screening. It says it's covered once every 5 years for patients without apparent cardiovascular disease signs and symptoms. Is that correct? I thought I heard you say screening. You said this test would not be covered. Under the preventive service program, and I don't know exactly if the 80061, and actually we can look to see.
Mary Sue, you want me to address this?
Oh, sure.
Okay, the 80061 is part of the cardiovascular disease screening tool, the lipid panel, and it is for patients or beneficiaries who do not have cardiovascular disease. So the lipid panel, the frequency is for those who do have it identified. This is for those who have not had any cardiovascular disease signs or symptoms that were identified, and Medicare, as part of its preventive services, will cover this every 5 years for those types of patients.
Perfect. Thank you, Jennifer. Jennifer is our resident preventive service guru. All right. And seeing that is the last question, and in the interest of time, I am going to proceed on with closing remarks, but I'll look back over to see if there's any questions before we conclude for today. So after the webinar is complete, those of you who logged into the webinar, you're going to receive an email. You will not receive this email if you only called in via the phone. The email is also going to be your proof of attendance, and it has contact hours on it if you need those for continuing education. So don't delete that email without reading it. If you can think of any follow-up questions regarding this event, email those to us at wps.gha.education@wpsic.com. And send those within the next week. Don't send us any PHI or PII. If you have something claim specific, you really need to go to customer service with those questions. We don't have access to the systems anyways to look up those claims, so you really need to go to customer service. If you have a question, you have the slide deck, you can simply click on this and it's going to populate an email for you. Just make sure you have something about lipid panels in the subject line. All right, as I stated at the start of this presentation, we really value your opinion. We want to hear from you on how we did on this event. So this survey really only takes a few minutes to complete, and it's really important for us as this is how CMS measures us. So we want your opinion. We want your feedback on how we did. Is it valuable? The best part about our surveys is it gives you the opportunity to tell us what else you need as far as education. What other types of education would you like WPS or myself to bring out to the provider community? So if you you have additional things that you want us to do education on, that is your best way to get that directly to our provider outreach and education team. When the webinar closes, you're going to get a pop-up box that looks like this. It's WebEx's way of saying you're going to an external site. It's just taking you straight to that survey. So you can take that survey and you don't even have to copy the link if you don't want to. Just one other quick thing before we close. We are committed to making changes to improve your educational experience. And these are things that have come to us directly through the surveys that we want to let you know we have made these changes for you. So when we post something to YouTube, whether it's an encore event or some other type of educational piece of information or educational video, we have now started adding chapters to those. So you can click right through to the section that you want to look at. We do encourage you to listen to the whole thing, but maybe you want to just go back to today's event and listen again about the indications of coverage. And that's the only section you want to review. So you can now do that. We've also added training indicators to our presentations. So that kind of alerts you to know, is this clinical? Is this billing? Is this documentation? Is it on FIS? Is it on MCE? So look for those in the information of the event. And then we also have a list of what those training indicators are on our training section page of our website. And finally, I want to let everyone know about an exciting opportunity. If you do not already know, we are hosting kind of a series of webinars that go on throughout the day on July 15th, and it's all things local coverage determination. So we're going to start with some background, general information. What are the LCDs? Where are they? How do we find them? Dr. Bahakas, one of our medical directors, is going to host this section where she talks about the development of LCDs, etc. So a big, exciting event that I do encourage everyone to take a look at, register for everything you want to go to or just the individual component. They're all open for anyone that wants to attend. And again, that's on the live events page. All right, and finally, on behalf of myself as well as Medical Review, we want to thank you for your participation in today's event. I want to thank you for giving me a few extra minutes of your day to finish up with the remarks and get to those last questions as well. So this concludes our webinar for today, and you may now disconnect.